This is a review for the entire topic of schizophrenia from the AQA Psychology A-Level paper 3, and it's updated to 2025. So the first topic is classification of schizophrenia. This is an AO1 only question, and it has been asked in 2024 last year. What they asked was the difference between positive and negative symptoms, and an example, as you can see, you need to know specifically about hallucinations and delusions for positive symptoms and speech poverty and avolition for negative symptoms. In summary, positive symptoms are like a plus, not a good thing. They're additional to expected behavior, and negative symptoms are something that is missing from expected behavior. Fixed false beliefs is the definition for delusions, and hallucinations are usually auditory, but they can be of any sense. Avolition is the loss of motivation to carry out tasks, and speech poverty is the reduction in the amount of quality of speech. This is not to be confused with disorganized speech, that is a positive symptom that is not named on the syllabus. That means that word salad, when people jumble up their words, mix up the sound and the meaning of words, but that's disorganized speech. That is a positive symptom. Speech poverty is basically a lack of or significant reduction in speech, and that's why it's negative. In this next topic, as you can notice, there are 8 key words to pay attention to: reliability, consistency; validity, whether you're measuring what you intend to measure; diagnosis, the process of assigning someone the label of schizophrenia; and classification, the systems we use to list what the symptoms of schizophrenia are. And within these issues, we have specific issues with comorbidity, 2 diagnoses happening at the same time, culture and gender bias that you're already aware of from issues and debates, and symptom overlap, where 2 distinct diagnoses will have some symptoms in common, so it's hard to tell which is which. Now, this has never been an essay yet, but it was an essay. It did come up as an essay in the previous specification, so we can't rule out that it may come up as a 60 mark, and we'll look at that in quite a lot of detail just to clarify what's the expectation in that respect. Reliability, culture and gender bias are the specific keywords that have not been assessed yet. So if it were to be a shorter question, it might be orientated in those areas. Obviously, be prepared for everything just in case. Now I've put here, if you want to pause and have a more detailed look, the mark scheme, also with the way to structure this essay. In the following slides we'll look at details about it, but in synthesis, for the outline, you will identify an issue, and for example, it could be reliability, it could be validity, it could be comorbidity, all the ones named. And there's also in the mark scheme other options, but you've got enough on the kind of prescribed syllabus, so I wouldn't suggest to go into other specific issues. And then you say why this is an issue. That's how you elaborate. You know, if you've ever get the comment, lack of elaboration, this is how you elaborate. This is an issue because, so you say why it's a problem. For example, symptom overlap is a problem because we don't know which diagnosis to give, bipolar disorder or schizophrenia, for example. And the last thing you must do when you present an issue is make it relevant to schizophrenia. So talking about, for example, culture bias in general and diagnosis, talking about, for example, the definition of abnormality, so deviation from social norms, is not enough. It has to be in the context of schizophrenia. Now, the AO3 is tricky. It's about a bit like in issues and debates. If the AO1 is an issue, then the AO3 is the implications. Yeah, consequences, negative and positives, advantage of raising the issue. For example, the classification system is getting better. Advantage in terms of people accessing treatment. Issues, consequences of the issues with the classification and diagnosis. And the best way to do this, although you might usually be used to doing all your AO1 and then moving on to your AO3, in this case, the best thing to do is to evaluate each issue as you go along to make it clearer that you moved on to evaluation, and it's important to separate into separate paragraphs the AO1 and AO3, and to signpost your AO3 using the starter sentences such as an implication of this issue, a consequence of this issue. When analysing this issue, one might argue. Make it completely explicit that you moved on to AO3 by separating it and signposting it. You can bring in research evidence as well in your AO3, and that's more straightforward, evidence for this issue, and that applies to some of the issues but not all of them. So this is the examiner's report from when it came up many years ago in the old syllabus. The main problem is that some students described clinical characteristics. Now remember, the previous topic about positive and negative symptoms is not relevant explicitly in this topic of issues with the classification and diagnosis, unless you say the issue with the reliability might be that you haven't completely empirically operationalized hallucinations, meaning that different diagnosticians might interpret them differently, something like that. But it's not about listing what schizophrenia is. You don't need to introduce this essay by saying what schizophrenia is and what the characteristics are. You delve straight into the issues. The best answers, as you can see, identified and then described the issue straight away. Lots of students didn't do well in this question. It wasn't very challenging. That might be the reason why it hasn't been assessed, but because paper 1 and paper 2 have been quite straightforward, it might be that they want to make paper 3 a bit more challenging. That would be a way they do so. So the do's are here, I've already mentioned them, but the don'ts, as I said, don't describe the symptoms, don't give general issues with classification systems, they have to be specific to schizophrenia, and don't confuse comorbidity and symptom overlap, because that was one of the most common mistakes. So make sure you've got clear notes on comorbidity and symptom overlap. Even if it wasn't an essay, if they ask you about one of these two or what the difference is, you need to be prepared to answer with examples. For AO3, if you have studied Rosenhan's study about the pseudo patients, that's a very memorable study and it's very significant for its time, but in reality it was carried out in 1973. Since then, there's been 3 reviews of the classification system, so it doesn't really apply to classification and diagnosis today, and you need to acknowledge that if you are going to talk about it. Also, talking in detail about the procedure and the findings is not really focused on the question. So you can mention it as kind of signposting the implications of misdiagnosis, but that shouldn't be the bulk of your AO3. As I said, the best students, as I showed you in the plan, identified the issue, then considered the possible consequence of the issue and research evidence, and that's why the plan was structured in that way, because of the examiner report from the previous syllabus. So for AO3s, don't focus on Rosenhan, don't evaluate Rosenhan. That's another thing. I told you it's an obsolete study, but evaluating Rosenhan is not going to give you marks because it's completely off topic. And here you've got the do's as a reminder. Plan your essay. As I said, you want to start with an issue is, this is an issue because, a consequence of this issue, yeah? And you would put these two as your AO1 paragraph, yeah? And then you would put the consequences as your AO3. Okay, so I just wanted to be sure that should this come up as an essay, you're confident in answering it. So let's have a quick look at the various issues. Validity is the extent to which the classification system measures what they intend to measure. So you can talk about specifically concurrent validity, and it will be easier if you bring in these specialist terms because it makes it clearer what you're on about and it makes it explicitly relevant to validity. Do the DSM and the ICD agree on the symptoms? Obviously, if the ICD and DSM have different symptoms or different timings of the presentation of symptoms, that's a lack of concurrent validity. Discriminant validity relates to symptom overlap. If we have symptom overlap, how can we discriminate whether this is actually measuring schizophrenia or another disorder? And also comorbidity is an issue with predictive validity. If someone has two diagnoses, how do I know how their symptoms are going to develop and affect them over time? Is one diagnosis going to prevail over the other, or are they going to kind of co-occur and they're going to have double the amount of symptoms? So in terms of evidence, so elaboration for concurrent validity, we've got evidence from this study showing that using the DSM, 26 patients were diagnosed by one practitioner and 13 by the other, and almost twice as many. So if you didn't remember the numbers, you can remember that the ICD generated about twice the diagnoses compared to the DSM. Comorbidity, the elaboration would be talking about the types of comorbidities with schizophrenia, for example, personality disorder, depression, addiction of many types, for example, alcoholism. Now, this is an issue because it's hard to establish whether one of the two conditions cause the other. So are they just co-occurring, or did one cause the other? For example, is someone addicted because they're self-medicating from the pre-existing symptoms of schizophrenia? Obviously, that will mean that you need to establish which one is the primary disorder. The relevance to schizophrenia, so explicitly here we've got 50% of people with schizophrenia also have a diagnosis of depression, so that's the most co-occurring diagnosis, alongside a very close second, substance abuse. Also anxiety disorders such as PTSD and OCD are about a quarter of schizophrenia diagnosis comorbid. So if we move on to AO3 for comorbidity, we can say that one of the consequences is that it will be harder to establish a course of treatment for those who are dually diagnosed. Comorbidity is also known as dual diagnosis, two diagnoses. This is because the clinician will have to decide whether to treat one or both disorders. If they choose to treat one, the other one might go untreated, but if they choose to treat both, especially if it's with drug therapies, it might overwhelm the patient's system. On the back of the previous point, another evaluation point here is that if schizophrenia is seen as the primary disorder that the other disorders stem from, that tends to be the case because schizophrenia is usually the most problematic of the diagnoses. What Weber found is that some other diagnoses might be completely overlooked. For example, in his review of 6 million hospital discharge records, he found that lots of people with schizophrenia had non-psychiatric diagnoses, such as asthma, hypertension, type 2 diabetes. So a primary diagnosis of schizophrenia sometimes means that the other non-psychiatric issues are completely overlooked. And this might exacerbate the prognosis and outcomes. If someone is struggling with physical disorders and discomfort, then their recovery from their psychiatric disorder is hindered significantly. On the other hand, as I said, two simultaneous treatments could potentially clash with each other, and they could also put someone under a lot of strain, as I said, especially if they're both medical treatments, drug therapies. Therefore, the predictive validity of diagnosis is hindered by the co-occurrence of different disorders with different courses of treatment, and that might also be interfering with each other. Symptom overlap is the second name issues, and it's linked to discriminant validity. Two conditions that share one or more symptoms make it difficult to discriminate whether someone should be diagnosed with one illness or the other. For schizophrenia, we've got examples such as bipolar disorder is the most prominent, when you talk about this, you want to explicitly name the symptoms that overlap with schizophrenia. Psychotic symptoms, so the positive symptoms of schizophrenia, the ones that co-occur with bipolar disorder in what we would call the manic stages of bipolar. So hallucinations and delusional thinking are ones that overlap, meaning that it's hard to discriminate whether someone should be diagnosed with schizophrenia or bipolar disorder, especially when they're having a psychotic episode. The consequences is that patients might be misdiagnosed. If they're misdiagnosed with one disorder rather than another, obviously that the consequence is that they have the incorrect course of treatment. This has significant implications for the economy. If you're treating someone with the wrong treatment, not only you're spending time and money on treating them, but it might actually make things worse, making it even more expensive to then reverse the effects of the misdiagnosis. So this will affect relapse rates, rehospitalization, and that's obviously extremely expensive. Just so you've got a bit of kind of hard evidence, you can mention this last point. The single price per day for an inpatient on adult acute wards is £429, and this is in the UK, and that would be the equivalent of 4 CBT sessions. That's a figure to remember because you can bring it up in lots of different areas in schizophrenia, not only here in symptom overlap, but that's just to kind of show awareness of not talking about economic implications generally, but talking about them in the context of a psychiatric hospitalization. There have been attempts to kind of identify the main symptoms that only schizophrenia has to make it more specific. Schneider tried to do this, talking about first-rank symptoms, so those most prominent symptoms that only people with schizophrenia have and nobody else, to allow that discrimination between schizophrenia and all other disorders. But unfortunately, that attempt completely failed. So we don't have any solution for this. There are still symptoms that are shared between different disorders, and the question of diagnosis in these cases is, in a cost-benefit analysis, it might be more costly than beneficial, and holding off from diagnosis might be more cautious. However, on the other hand, obviously someone not having a diagnosis at all prevents them from access to treatment. So it's an impossible question to answer. Now, as I said, comorbidity and symptom overlap relate more to validity. Am I measuring what I aim to measure? Am I measuring something else? Am I measuring schizophrenia or bipolar disorder? Is schizophrenia the primary disorder, or is it a consequence of something else? Whereas culture and gender bias obviously relate to reliability of classification, because if someone is biased, then they might give a different diagnosis than someone who has a different bias or is not biased, potentially. So the question is, can two different diagnosticians produce the same diagnosis? And that's called inter-rater reliability. If one diagnostician has a beta gender bias and the other one has an alpha gender bias, that might result in two different diagnoses, and that is very problematic. So as we can see, you can use the same study that we talked about before, because you could compare the ICD and the DSM, but in this case, you can look at the two diagnosticians, and again, we can see that one diagnostician was much more kind of liberal in their diagnosis than the other, meaning that the inter-rater reliability tends to be approximately the flip of a coin, about 50-50. So there's a 50-50 chance that two diagnosticians will agree on the diagnosis. That's obviously a massive concern, and it's an ongoing concern. And then for further elaboration, you can talk about this report, Understanding Psychosis and Schizophrenia, where they explain the lack of reliability with clinicians having a diagnostic preference. So being kind of accustomed to give one diagnosis or another, and that might explain why there's a strong disagreement in diagnosis of schizophrenia. As you can see, you can link reliability to both gender and culture bias. So if you've got a question on reliability, you could tie it in with gender bias and then use evaluation points for all three together. So what gender bias is kind of self-explanatory. It's making differences in diagnosis based on a person's gender. This is obviously an issue, and it's twofold. A patient might receive a diagnosis of schizophrenia that they don't need, or vice versa, a patient might not receive a diagnosis of schizophrenia, which they do need. And we've got a significant amount of difference between men compared to women, and that's since the 1980s. So for the past about 45 years, men have been much more likely to be diagnosed with schizophrenia than women. It's quite interesting that this is a relatively recent issue, meaning that it's more likely to be down to bias rather than to pre-existing predispositions of men compared to women. Because there's no objective way of classifying schizophrenia, the issue with low reliability is prevalent. For example, here we've got a study on male and female psychiatrists looking at vignettes, so descriptions of patients' behaviors, and the same description, if the patient was described as male, there was a 56% diagnosis rate, but if the patient was classified as female, it was only 20%. So almost triple the chance of being diagnosed with schizophrenia, even presenting with the same identical symptoms, if one is male rather than female. So that's hard evidence for the issue of gender bias. Obviously, the consequence is that women might be missing out on treatment, and men might be overdiagnosed. Female patients might be not diagnosed because they mask their symptoms or because they function better. So we can bring in a bit of analysis in AO3, but also they might be diagnosed with a different disorder. So it's not necessarily that it's because they function better. It might just be that the label of schizophrenia is seen as a more male-specific. Culture bias is obviously when the culture of an individual, both on the patient side and on the psychiatrist side, might skew the likelihood of a diagnosis. This is an issue because a person might receive a diagnosis of schizophrenia because of the culture they belong to, rather than because of the presentation of specific symptoms, and also if the diagnostician is of one culture that mismatches the culture of the patient, the risk of culture bias is significantly higher. In terms of schizophrenia, we know that African Americans and English people of Afro-Caribbean descent are more likely to be diagnosed. And this is clearly a culture bias, not a predisposing factor of certain ethnicity, because the rates of schizophrenia in Africa and the West Indies, where obviously we'll have the most people of this descent, are not above average. That seems to suggest that it's because of the mismatch between the culture of the diagnostician and the patient that people of Afro-Caribbean descent are more likely to receive a diagnosis of schizophrenia. If we move on to analysis, we might explain that cross-cultural diagnosis might be a problem because hearing voices is something that culturally is seen as advantageous and desirable in certain cultures, but not in other cultures, meaning that someone might be quite forthcoming in talking about hearing their voices, but in a, for example, a highly kind of industrialized Western environment, that might be seen as a symptom of a psychiatric disorder rather than just a kind of blessing. So here we see in this cross-cultural research looking at adults from Ghana, India, and the US, so 3 different cultural origins, and it's about their experience of a specific symptom of schizophrenia, that is hearing voices, as mentioned before. Now, in the US, this was seen as something uncomfortable and it was seen as a symptom, but in India and Ghana, that wasn't. Now, the implication of this cultural viewpoint is that the people in the US were more likely to hear violent and hateful statements. This is significant because it means that the attitude, the cultural attitude towards the symptoms of schizophrenia, specifically the positive symptom of auditory hallucination, has an impact on the nature of that symptom. Obviously, because these hallucinations are self-generated, if someone is very anxious and worried about those symptoms, then they're more likely to manifest in a negative scary, hateful way. Whereas if someone kind of embraces them and accepts them, they're more likely to be benevolent, maybe narration, hallucination, where you just hear a voice saying what you're up to in that moment. So that means that in our Western culture, there might be much more stigma around the symptoms. It might also be more shocking from someone from a different culture to be kind of judged and seen as abnormal and defective for something that they would see as maybe a gift or something positive. This also obviously will lead to unreliable diagnoses, because someone from a Western culture might assume that hearing voices is pathological, and therefore give a diagnosis when there's no failure to function adequately and the person is living quite happily with those voices, meaning that treatment is wasted and it's not helpful for neither the patient nor the economy. Now we're going to move on to biological explanations for schizophrenia, and here we've got specific aspects named: genetics and neural. So genetics, about inheritance and DNA and specific genes associated with schizophrenia. Neural, everything to do with the brain, brain structures, brain circuits, neurotransmitters. It was an essay in 2018, and in 2020 there was an essay, but the evaluation part was a comparison. So the AO3 part was comparing to family systems explanation for schizophrenia. So that just reminds us that we can expect comparison questions in paper 3 as well, not only in the approaches section of paper 2. It was an applied, there was a general applied explanation essay, meaning talking about explanations for schizophrenia, including psychological and biological. So a pure biological explanation for a schizophrenia essay hasn't come up since 2018, but in 2020 there was one addressing biological explanations in the AO1. Now for genetics, you just talk about twin and family studies and look at concordance rates, comparing either the relatedness of individuals. For example, if your parents have schizophrenia, you've got about 50% chance of also developing schizophrenia or getting a diagnosis of schizophrenia. If only one parent has it, it's a third of that risk. And if a sibling has it, it's slightly lower, but around 10%, 1 chance in 10. The concordance rates for identical twins are significantly higher, about 5 times higher than for non-identical twins. But still, you can compare this figure to the overall incidence of schizophrenia. So over the entire population, there's a 1% chance of developing schizophrenia. So that 7.4% for non-identical twins means that you're still 7 times more likely to have schizophrenia if your non-identical twin has it. But if you have an identical twin with schizophrenia, then you're 40 times more likely than the general population to have it. Putting that in perspective, using that 1% reference just gives more significance to those rates. In terms of genetics, there are lots of kind of large-scale studies, and there have been lots of attempts to identify a specific gene associated with schizophrenia. Here we've got a genome-wide study of 5,000 cases of Swedish nationals with schizophrenia, and they found 22 loci for associated at genome-wide significance. 13 of these are new. 1 was previously implicated with bipolar disorder. That means, in summary, without you having to remember this, is that many genes and clusters of genes have been associated with schizophrenia. You see 13 clusters of gene have been associated with schizophrenia, meaning that it is polygenic. We never have found 1 single gene that has been implicated directly with the development of schizophrenia. There are multiple contributing candidate genes, meaning that the genetic explanation has been inconclusive so far in terms of predicting whether someone will develop schizophrenia. We can't carry out a genetic test, neither to predict schizophrenia nor to diagnose schizophrenia. In terms of AO3, you can give the usual critique that twin studies don't account for the environment that is shared. So that has been addressed by adoption studies. This is a very important study, TNRI, because you can use this as well when you look at family systems theory. That might be a reason why they compared biological and family system, because there's obviously a nature-nurture question there. So these are children adopted that had a biological mother with schizophrenia. Now, 6.7% of these children received a diagnosis of schizophrenia, and that means that they were 7 times more likely than the population to develop schizophrenia, showing some genetic link. We can see that 2% in the control group, so that's ruling out that adoption is the cause. However, the 2% is slightly higher still than in the general population. But if we compare these two figures, we see that still children with a biological mother with schizophrenia are about 7 times more likely than the general population, and even 3.5 times more likely than their control counterparts to develop schizophrenia. So what we see here is that, yes, genetics are definitely a risk factor in the development of schizophrenia, but they're not the sole explanation. So it does support nature. However, this is really important, and that's where the family system comes in. However, those who were adopted in a problematic family environment, one with high levels of expressed emotions and hostility, were more likely to receive the diagnosis. So it's actually, this is more of an interactionist explanation. So you can use it to argue for the role of genetics, but also how it's incomplete, and we have to account for also environmental factors. As I said, there is no specific gene associated with schizophrenia. It's polygenic or heterogeneous. There are different combinations of factors that can lead the condition, and these factors are both a variety of genes and environmental matters. So this is a reductionist explanation that really has come to no kind of significant conclusion, and we don't have an answer yet as to whether there's a schizo gene. This was a misconception many years ago that has been overcome because we have no conclusive evidence. Now, when we talk about neurocorrelates, it means anything in the brain that has been linked to schizophrenia. In terms of parts of the brain, negative symptoms such as avolition have been associated with low activity in the ventral striatum that is involved in the anticipation of reward. So it makes sense that having little motivation to do anything might be, in part at least, caused by a low sense of not feeling rewarded by any activity. You can also use these explanations in the cognitive explanation, because obviously it's looking at what cognitive processes such as reward and motivation are linked to the symptoms of schizophrenia. And for positive symptoms such as auditory hallucinations, we've got lower activation in the superior temporal gyrus. You know that the temporal lobe is where the Wernicke area is involved for language understanding. So it makes sense that an auditory symptom might be associated with that area of the brain, a malfunction in that area of the brain. In terms of AO3 for this part of neurocorrelates, obviously it's correlational. We can't find any causal relationship between these two factors. We don't know if it's the schizophrenia itself that has caused damage in the functioning of the brain, that therefore we can find low functioning in certain areas. Was the schizophrenia a kind of infection or disease or autoimmune disorder that ate up parts of the brain and its functionality? All research is not in agreement. Not all not all researchers identified the same parts of the brain as implicated with schizophrenia, so we've got no conclusive evidence and no consistency in the evidence. And there are definitely structural abnormalities in the brain with people with schizophrenia, but as I said, we can't tell whether those are caused by the schizophrenia or are the cause of the symptoms of schizophrenia. The most famous part of the brain, well, element of the brain that has been associated with schizophrenia is in large ventricles. In ventricles are actually the gaps between the folds of the brain, and therefore them being enlarged means that there's a lot of scar tissue and damage in the brain, meaning that there's less brain matter that is functional. This has been seen longitudinally to get bigger and bigger, so the damage gets bigger and bigger over time, showing that schizophrenia is probably a disease that is degenerative, and the brain loses its function more and more over time. That's what we know. All right, so the dopamine hypothesis is named on the syllabus, so they can ask you explicitly about that. They could ask you in general about neurocorrelation, correlates. They could ask you in general about biological explanations, but they could also ask you a more specific question just about the dopamine hypothesis. We can't rule out that that couldn't be a 16 marker in its own right, because there's quite a lot to say. It's the most famous and prominent biological explanation for schizophrenia. Now, there are two aspects of the dopamine hypothesis: the original dopamine hypothesis and then a second one. The first one is more focused on positive symptoms, and it's to do with hyperactivity, so an excess dopamine in certain areas. For example, hyperactivity in Broca's area has been linked to disorganized speech. Now remember, I said disorganized speech is about that word salad, loose associations, talking a lot, connecting up words that don't necessarily have logical meaning to associate them, but they might sound the same. And that's different from the negative symptom of speech poverty, so do not confuse those two. The idea is that excessive dopamine in these D2 receptors, so the dopamine receptors, results in more dopamine binding and therefore signals firing, or these receptors being oversensitive and therefore responding more sensitively and more kind of enhanced response to that dopamine. So on the other hand, unsurprisingly, the second dopamine hypothesis is more focused on negative symptoms. It's a hypodopaminergia hypothesis, saying that a low level of activity, dopamine activity, might result in negative symptoms. For example, low activity in the prefrontal cortex that is responsible for decision making might be associated with symptoms such as avolition. Evaluation, we can use PET scans and other neuroimaging techniques to show that there is an increase in dopamine in certain areas, for example, the striatum. So there is empirical evidence to support the dopamine hypothesis. Also, the evidence that drugs that block the transmission of dopamine have reduced psychotic symptoms, so the kind of positive symptoms of schizophrenia, seems to be evidence for dopamine being implicated. If we've got dopamine antagonists reducing the symptoms of schizophrenia, then we can reverse engineer our way to thinking that dopamine was in fact one of the causal explanations for schizophrenia. This does not support all schizophrenia. It supports the hypodopaminergia hypothesis of high levels of dopamine being associated with positive symptoms only. So we will see that the evidence for the role dopamine plays in positive symptoms is much more consistent than the role it plays in negative symptoms. The issue, therefore, is that schizophrenia, being a disease that includes positive and negative symptoms, cannot solely be explained through dopamine, because other neurotransmitters such as glutamate, serotonin seem to be implicated, especially in those negative symptoms. And when we look at drug therapy, we'll see that certain drugs will work, but only for positive symptoms, and drugs that address other neurotransmitters are more effective for negative symptoms. So it's oversimplifying schizophrenia because it's looking only at certain symptoms. There's also the treatment etiology fallacy. That means that because the treatment is effective, that doesn't automatically mean that it's causal explanation. The example I always give is, if I have a headache and I take aspirin and then the headache goes away, that doesn't mean that my headache was down to a lack of aspirin in my system. And therefore, assuming that a treatment provides to us a causal explanation is a fallacy, is a mistake, and therefore this is unscientific. It's unscientific to draw causal conclusions when in fact we don't have any evidence of this being the causal explanation. So now moving on to psychological explanations for schizophrenia. Family dysfunction, as I mentioned before, was an AO3 section, part of the biological essay, so only comparing the biological to family systems theory. And then there was a general essay in 2023 on all explanation. It was also a specific essay in 2024. So I would say that it's unlikely to come up as a 16 marker this year, and you should prepare more on specific details and being able to apply the concepts of a double bind and expressed emotion to specific scenarios. So double bind theory is basically a mismatch of verbal and non-verbal messaging that happens during childhood, usually on behalf of a parent. That means that although a child is encouraged to speak out freely, they're going to be criticized or silenced whatever they do, because they might be told, oh, come here and hug me. So the verbal message is one of affection, but the non-verbal might be that the person is saying that with a very stern look on their face, saying, come here and hug me. The tone of voice and the facial expression doesn't match the message of affection, so the child doesn't know, is the parent angry or do they want affection? So the child doesn't know how to respond, but they feel that they're forced to do so. So for example, there's no counter communication possible. Asking what the valid message is unacceptable, and the parent will shut that down and saying, how do you not understand this? But also the child can't walk away. If the child was to try to walk away from that situation, not knowing how to respond to it, then they would be punished for it. For example, with the withdrawal of love, the silence treatment. So the child is stuck between a rock and a hard place, having to respond to a very ambiguous message. Once we understand that, it makes sense that if you don't know what's going on and you don't have a clear message, one strategy to cope with this communication pattern is to ignore the primary communication and respond only to meta communication, so to non-verbals. That means that the symptoms of kind of paranoia and delusional kind of paranoid delusion might start arising, being suspicious of everyone's words, wondering what the true meaning of things, focusing on micro expressions, gestures, looking for clues as what might be the right answer. And in the long run, that means that a person will have a break from reality as a form of extreme coping. So breaking from reality, becoming delusional, psychotic, and also that flattened affect, not having facial expressions, that avolition, not having any motivation, is actually makes sense as a coping mechanism to this dysfunctional communication. The second explanation of family dysfunction is expressed emotion, and this is more linked to relapse rather than as a causal explanation for schizophrenia. And it's stating that expressed emotion, it means negative emotions being expressed, criticism, disapproval, picking on someone, unpicking every defect that they might have going on. So obviously for people with schizophrenia, and anyone, this is a very stressful, anxiety-provoking environment. Going back into a household where you know there's going to be a lot of hostility and criticism might cause distress that makes recovery very difficult and relapse very likely, because you'll become preoccupied with the family dynamics. So, in terms of evidence, we do have evidence for communication patterns of families with schizophrenic members compared to those without do show more contradictory and unclear communication in the families of schizophrenic patients. So these patterns have been identified in families with patients with schizophrenia, therefore showing that there might be an element, they might be a contributing factor to the development of symptoms. Another strength of psychological explanations and family dysfunction specifically is that compared to biological explanations, they are more holistic. They consider, in this case, the complex interactions between social, environmental, and psychological factors. So they give us a much broader and more valid, potentially, picture of what is happening in the life of a person to develop schizophrenia. We've also got evidence that expressed emotion is higher in family with patients that have higher levels of relapse. Relapse is something that has been measured through rehospitalization, so we do have empirical evidence to suggest that relapse rates are higher in families that show high levels of hostility in their conversations. In terms of implications, knowing about the impact of all these factors has led to the development of family-based intervention, looking at not only the individual in isolation, but the individual within their environment, and trying to reduce the levels of relapse. So that, in terms of implications for the economy, is a good investment in preventing relapses, and therefore also in terms of economic implications, saving money. There's that £450 a day of hospitalisation to the NHS. Now, in a review of 46 studies, 69% of female inpatients with schizophrenia and 59% of male patients with schizophrenia experience abuse in childhood. So what that means is that what happens in the family is the level of kind of love versus the level of conflict and negativity does seem to be prevalent in patients with schizophrenia. Obviously, we have lots of questions about this data. Mainly the fact that if someone with schizophrenia is experiencing psychosis, so they're in a delusional state, self-report and retrospective data are very, very questionable in terms of their validity. How can we trust? In general, we can't really trust people's memory, but in this case, even more so, because the person is potentially in a psychotic state. So the questions on the validity of this data are very significant. All the evidence is obviously correlational. What that means is that we can't rule out that the distress of having a child with a serious psychiatric disorder might be something that is very stressful for families, puts a strain on the family dynamics. We can't be sure that families with a person with schizophrenia in them don't have this level of kind of hostility and negativity because they're really struggling with dealing with supporting their family member, and at the same time maybe supporting other children in the family. In terms of ethical implications and social sensitivities, we can also say that blaming the family is usually more harmful than helpful. Already, they've got a family member with a psychiatric disorder. On top of that, you're telling them that it might be their fault. That's very unhelpful. And the costs ethically seem to outweigh the benefits of this theory. The second psychological explanation for schizophrenia is cognitive explanation. This has never been a 16 marker. It was only an option of the general applied question in 2023, so it's definitely one to be prepared for. It's quite complex, but you can kind of simplify it as much as you can. As I said, you can talk about the anticipation of reward and therefore motivation being lower in people with schizophrenia, and that could explain negative symptoms. The most prominent cognitive explanation for schizophrenia is Frith's meta-representation system theory. The meta-representation is the ability to reflect on one's own thoughts and behaviors, and the ability to attribute one's own thoughts to oneself and other people's thoughts to others. So dysfunction in this system can lead to an inability to, for example, recognize our own thoughts as our own. So if I have a thought, but I don't have the ability to identify it as my own, then it makes sense that I experience it as a hallucination or a delusion of thought insertion, for example, thinking that some entity can put thoughts in my mind. The opposite can also happen, where if I can't attribute other people's thoughts to themselves, then I might, if they say something, I might think, oh, I was thinking that, so they're reading my mind. So all this delusional thinking can be linked to a faulty meta-representation system. Frith also talks about a central control system that is an ability to suppress automatic responses while we perform deliberate actions. So it's something to do with basically what we would call the central executive in the working memory model. So if you can't filter out what's relevant and what's irrelevant, you will be overwhelmed by sensory experience, meaning that you will be kind of frozen into inaction. So negative symptoms such as speech poverty can be explained through this inability to rule out what matters and what not, and therefore being kind of stuck into inaction, overwhelmed. And this is true that some patients with negative symptoms will not even be able to engage in basic tasks such as listening to the radio or watching TV, because that's too much, and the only thing that they could do is sit and look at a static image, because anything more than that would be completely overwhelming. Another cognitive explanation is by Hemsley, and he talks about the breakdown in the relationship between the information that has already been stored in memory and new, so not being able to remember what has been kind of acquired and what hasn't. This also talks about this sensory overload. If everything that I'm processing seems to be something I'm processing for the first time, and I haven't developed any schema and any memory for it, then again I won't be able to cope with my environment. I won't know what is real and what isn't, and there will be kind of this mental confusion that might also lead me to attribute what is in my memory to an external source, rather than recognizing that it's something that I have in my brain from before, and that might be linked to also hallucinations. Now, for AF3, we've got research comparing schizophrenic patients with control patients. This is using a Stroop test that we know is used to test central executive abilities. And as expected, people with schizophrenia took twice as long to suppress the impulse to say one color instead of the word, showing that their ability to control their decision making, that central executive, is definitely at fault in people with schizophrenia. Another study is looking at specifically people with positive symptoms, schizophrenic patients with hallucinations in this case, and looking at whether they could remember whether they had said a word or not. And they were asked to generate categories themselves or read out pre-existing categories. And then 1 week later, they were asked to choose which words they had generated and which ones were given to them. People with schizophrenia with hallucinations were much worse than people that didn't have hallucinations, still with schizophrenia, in remembering which words they had generated and which ones were pre-existing. Both groups were worse than people without schizophrenia, showing that those issues with memory, recall, are prevalent in people with schizophrenia and more prevalent in people that experience hallucinations. As per most explanations for schizophrenia, we don't have any causal explanation. It's impossible to have a causal explanation with schizophrenia, because we'd have to kind of study young children from birth and look at cognitive impairments and then see whether those cognitive impairments result in the symptoms of schizophrenia. And that is something that the chances are so low, only 1% chance of the child having schizophrenia, that the resources necessary to run such longitudinal studies are really not available. In terms of studying people with a family history with schizophrenia, there's ethical constraints of, and also the idea of kind of self-fulfilling prophecy and stigma around the disorder that might make people unlikely to consent, and also even asking them might be ethically questionable. Okay, there's also research on brain damage patients that shows that some of these patients have cognitive impairments, for example, memory and perception impairments, but that doesn't mean, that doesn't result in them developing schizophrenia. Okay, they fail to develop the symptoms of schizophrenia, meaning that again, cognitive impairments might be an exacerbating factor like we said for genetics, but they're not the sole factor. The reality of schizophrenia is that there's so many variables involved in the development of schizophrenia, it's impossible to pin one down. Here, if you want to pause and make some notes, it's an essay plan for schizophrenia. Just a reminder again that these are also all on Quizlet. Moving on to drug therapy, typical and atypical antipsychotics are named in the syllabus, so be sure that you're prepared not for just a drug therapy in general answer, but for an overall knowledge on the difference between typical and atypical, some examples for both, and how they work differently from each other. There were shorter essays, not a 16-mark essay, in 2017 and 2022, so it's been a while since it's been assessed and it's never been a 16-marker. Typical antipsychotics, also known as first-generation antipsychotics because they were developed before the 1950s. One example is chlorpromazine. Make sure that you do know one name for each type of antipsychotic. They work unselectively by blocking D2 receptors. So we talked about the fact that we need to reduce dopamine activity through drugs. And what they do is they block dopamine receptors unselectively. It means that they bind very tightly to all dopamine receptors. By doing that, they reduce both the activity in the mesocortical pathway that is responsible for negative symptoms and the mesolimbic pathway that is responsible for positive symptoms. And you can see these both in this picture, just to get a visual idea of both of these. And as you can see, we already looked at how the prefrontal cortex is involved in negative symptoms, and whereas these kind of language areas are more involved in positive symptoms. Atypical antipsychotics are also known as second generation, so from the 1950s onwards. And one example, the most famous example, is clozapine. They block the D2 and D4 receptors selectively. So just to clarify, unselectively means any dopamine receptor in the typical antipsychotics was blocked, whereas in the atypical, the newer antipsychotics, only specific types of receptors are targeted. Also, in terms of how they bind, typical antipsychotics got kind of jammed in the receptor for quite a long time, whereas these ones are more loosely bound, meaning that there's fast release. We'll see that that has implications for side effects. The side effects of typical antipsychotics are much more severe than those of atypical. The mode of action is very similar. As you can see, it's just the kind of nuances. It makes sense that the newer drugs address some of the issues of the previous drugs, that they blocked all receptors unselectively and that they were tightly bound. So these ones address these two issues. The third thing that they do is affect not only dopamine but also serotonin and glutamate transmission. So these are more effective for negative symptoms compared to the older typical antipsychotics. Now, when you evaluate therapy, you always talk about effectiveness and appropriateness. In terms of effectiveness, do they work better, worse, or the same as alternatives, and in this case also placebos? On average, 70% of patients show symptom reduction after using antipsychotics, 30% show minimal improvement, and 10% do not respond to drugs at all. Chlorpromazine compared to placebo showed improvement in function and reduction in symptoms. Meltzer also found that clozapine is more effective than typical antipsychotics and 30 to 50% more effective for those who don't respond to original treatment. So clozapine is seen as the golden standard of drug treatment for schizophrenia. However, we'll see in the appropriateness that it's never the first option because of the risk that it brings in terms of side effects. It's the most risky of them all. So typical antipsychotics had these specific symptoms. So these two are for first generation antipsychotics, whereas these ones are specific to clozapine. So first generation had extrapyramidal side effects. That means loss of kind of muscle control. The idea is that dopamine, an excess dopamine is associated with psychosis, but a lack of dopamine has been associated with Parkinson's disease. So people with typical antipsychotics sometimes, because they're so tightly bound, have an excess reduction in dopamine that leads to Parkinson-like symptoms. Tardive dyskinesia is a symptom that has been seen in Parkinson and is also seen in patients that have used typical antipsychotics, and that usually, if it does occur, it will be irreversible in 75% of cases, and about a third of people on typical antipsychotics do develop these side effects. So they're quite significant side effects. There's always still a cost-benefit analysis to be made. If a patient is highly dysfunctional, doesn't function in society, maybe has suicidal ideation, then the costs of these side effects might still be outweighed by the benefits of re-entering society functionally to some extent, even if they have these Parkinson-like symptoms. On the other hand, clozapine is the only drug that can affect white blood cells. In a very small amount of patients, the immune system basically breaks down as a result of adopting clozapine. That means that it can only be prescribed after 2 other drugs have failed, because it's the only one with a potential side effect of a risk of death in a very, very small 8 in 1,000 patients. Again, if you want to pause the video and take a look at the plan. Moving on to cognitive behavioral therapy in the use of for treating schizophrenia. There was a general applied family and CBT essay in 2021. So CBT has been never asked in its own right in any shape or form. You could maybe expect an 8 marker rather than 16 marker, but it's been a while, so it's one to be prepared. Therapies have not been assessed for a longer amount of time compared to explanations, so they're ones to be mindful of. The aim of CBT is to help patients live with their condition. So CBT doesn't aim to remove symptoms and the condition. It's more a mindset of being able to live with the symptoms, because the symptoms now have been seen as more biological than social, and we've kind of gone beyond the family system theories and we see it as a brain disease. There's no point in trying to change those symptoms, and therefore CBT sees that the most useful thing to do is helping the patient manage them, live with them, and feel maybe less negative about them. So first of all, obviously in any talking therapy, you will develop a relationship with the patient and look into their motivation to change. What are their goals? What do they want to achieve? Maybe they want to go live by themselves, or get a job, or have a relationship. So that will be what kind of motivates them to attend the therapy. And then you will go through psychoeducation, so helping the patient understand about their illness and also how therapy will work, and kind of linking back to these features here, the aim and rationale. After that, skills training includes things such as self-management. Yeah, for example, if a patient with schizophrenia struggles to find the motivation to get up, to wash themselves, to keep themselves a kind of high level of hygiene, that's something that is significant because it will affect them also socially. People won't want to be around someone who is not clean and never changes their clothes. So that will be helpful also for them to kind of re-enter the social world. How to find support and where, so these practical skills, maybe role-playing certain exchanges and interactions, and as I said, life skills, you know, how to maybe catch a bus or apply for a job, real things that can motivate the patient to keep coming, to improve the quality of their life, that drugs won't do for them. In terms of specific symptoms of schizophrenia, it's trying to look at delusions and hallucinations, for example, and these are being challenged. Like in other forms of CBT, it's challenging dysfunctional thinking in order to help recognize that hallucinations are not real and therefore learn strategies to live with them, but with the awareness that they're not real, zoning them out and ignoring them and kind of going about one's own life. The effectiveness of CBT has been found to be small but effective on both types of symptoms. Probably it's more to do with a kind of general improvement in quality of life that obviously will not change the symptoms so much, but maybe the perception of those symptoms, meaning that a patient might feel a bit less negative about their condition. In terms of satisfaction, we do have a lower dropout rate and patient satisfaction when we have CBT combined with antipsychotic, meaning that they help each other. The antipsychotics will help keep the symptoms at bay, and the CBT will keep the motivation to keep taking those antipsychotics despite the side effects, knowing one's long-term goals. So of course a combined treatment is the most desirable and the most effective. As I said, the symptoms are not eliminated, but the distress associated with the symptoms does seem to be reduced. So they do have an impact on the psychological well-being of the patient. And these effects seem to be fairly long-lasting, although it's always needed for any talking therapy to consider having top-ups every now and then. CBT is only appropriate for those that can have a conversation. So obviously if someone is suffering from severe avolition, severe speech poverty, remember to link this explicitly to schizophrenia, not talking in general about CBT, then they won't be able to access the talking therapy. At the same time, if someone is in a severely psychotic state, sitting them down and talking about their goals is obviously completely inappropriate. Patients with schizophrenia often are not deemed suitable for CBT because the psychiatrist will not recommend that as a form of treatment because of their belief that they won't fully engage with the therapy. And especially older patients are less likely to be referred. So this is an issue because the issue might be a lack of access to CBT rather than a lack of an ability to engage with it. So there's an ethical question surrounding the pre-existing bias of GPs and psychiatrists towards talking therapies that might prevent people from improving the quality of their life. Another thing that talking therapies will do is improving indirectly the effects of drug therapy by increasing compliance. If someone is motivated, they see their long-term goals and what they want to achieve, it might motivate them to keep taking their drugs, as I said, even if they present with side effects. Family therapy is the same in terms of when it was assessed as CBT and also could be expected to be an 8 marker. The aim of family therapy is mainly to reduce the negative dynamics within the family system, to reduce the risk of relapse in the patient. The way it's done, like in CBT, there's an educational element, but in this case it's not only the patient that learns about their disorder, but also the family members. This is very significant because it can help the families not feel responsible, understand why the medication is so important, and also feel involved in the recovery process of their loved one. In terms of looking at the dynamics between the family members, the aim is to improve communication styles, learning about what expressed emotion is and trying to kind of monitor it and maybe change the way the people communicate with each other in the family environment, but also adjusting expectations. As we said, a person with schizophrenia will have ongoing challenges in their life, and family members putting the pressure on them to kind of just be cured is actually probably more stressful than helpful. For all the family members, not only for the patient, it would be important to expand social networks and maybe access support systems, support groups, because as we have understood, schizophrenia is a very stressful condition, not only for the person experiences, but also for the people around them. It's important to recognize that family therapy is a relational therapy. So the therapist, first of all, will want to cooperate with the family, learn their language, learn how they interact, and not feel like they're dictating a certain way of behaving or dictating a certain way of talking in order to develop that trust. Only once the trust is established and the therapist kind of joins, figuratively speaking, the family system, can then they facilitate questioning the patterns of communication and maybe suggesting new ways of communicating, but that has to be done with a lot of caution to not kind of scare the family away and make them put them off the whole therapy. In terms of psychoeducation, family and patients are all trained to recognize the early signs of relapse, so maybe seek help before the condition escalates to a rehospitalization. In terms of effectiveness, there's a lot of evidence that research has showed that it reduces relapse rates significantly. Patients' symptoms were less severe when they were attending family therapy, and they also had a significant lowering of rehospitalization cases. In a large-scale meta-analysis, again, it was found that cross-culturally there are some differences. For example, in terms of the mental state of the patient, there were mixed reviews looking at Europe, Asia, and North America. Some studies reported an improvement, but others did not. In terms of compliance with medication, it was found that those with family intervention complied more with their medication. That was found cross-culturally. In terms of social functioning, there was a minimal improvement, and very few of the patients had concrete outcomes such as living independently. So we can see that there are some cross-cultural variations, some positive outcomes universally, and some aspects that family therapy hasn't really been able to address. Obviously, in terms of appropriateness, the nice recommendation is that family therapy should be part of the intervention and supports offered to people with schizophrenia, and it has been associated with significant cost savings. If you think about that figure, those £450 approximately spent on every night a person is in hospital, then subsidizing family therapy treatment, if it halves the risk of relapse in terms of rehospitalization, that is really a significant investment. The extra cost of family intervention is offset by a reduction in cost of hospitalization. This is a really important feature. Also, family interventions reduce relapse rate for a significant period of time, even after they complete it. So the investment is definitely pays off with family therapy. And here is your plan for family therapy if you want to make some notes on it. Token economies are not a therapy. They're used, as it says on the syllabus, to manage schizophrenia in institutional settings rather than treat the symptoms. This was only a multiple choice question in 2022. It's never been an extended question, so it's unlikely to be a 16 marker, but it could be a mini 8-mark essay, or there could be a more extended question asking to evaluate token economies as used in the treatment of schizophrenia. So the idea is that people with schizophrenia make choices that are dysfunctional because of their kind of dysfunctional thinking pattern, and therefore also because of their memory issues, they will struggle learning new skills or learning appropriate skills. So behavioral treatment is aimed at kind of reinforcing desirable behaviors and kind of suppressing undesirable behavior to shape the patient's behavior into a more socially desirable and acceptable behavior. So it's a kind of step-by-step, layer by layer, moving towards the desirable behavior, assuming that people with schizophrenia don't have that innate ability to acquire behaviors as appropriately as their kind of neurotypical counterparts. So you see, you want to talk about token economies in the context of schizophrenia, not token economies in general as a treatment. That's what will make or break you if you get this question. Okay, so you all know about reinforcement, about tokens, etc. That's all. This part is all explaining token economies in general, but this is the part that you want to remember to include where you make it relevant to schizophrenia. In terms of AO3, there's research to show that behaviors such as hair brushing, bed making were improved in the case of this psychiatric hospital. Now, what's interesting is not only it improves the social skills of the patients, but also it increases staff morale. Now, there are arguments to say that this is something that is done for the people around the person with schizophrenia rather than the person with schizophrenia themselves, but you can develop that point, because actually if staff are feeling a bit better about going into work and a bit more positive about their patients, probably the service that they provide will also be better, meaning that everyone is a winner. So don't just go into kind of its controlling system, because actually it's more nuanced. In terms of appropriateness, it can be argued that for lots of patients with schizophrenia, token therapies have been replaced with social and life skill training, because they might not be as dysfunctional as to only require learning to brush their hair and brush their teeth. It's a bit more sophisticated than that. However, on the other side, token economies might be, for some patients with schizophrenia at least, the best and only option, because some patients are much less responsive to social rewards. What that means is that reinforcement through "I'm so proud of you, that's wonderful," doesn't really affect them at all, whereas giving them a token, a food, or something tangible might actually be reinforcing, where social responses are not, and therefore token economy for some patients with schizophrenia are the best way to show any kind of improvement. Like any token economy, this point is always valid. They can only be used in an institutional setting, so the applicability is limited. And since it's never been an essay of any shape or form, make sure that you're prepared for this one, and make sure, as I said, to explicitly link it to schizophrenia and the symptoms of schizophrenia, rather than making a generic token economy answer. So the last topic in schizophrenia is the interactionist approach in explaining and treating schizophrenia. As you can see, there are two aspects here addressed: explaining and treating. When it was asked as a 16-mark essay 6 years ago, they addressed both explaining and treating. So what we could expect is that they might ask a smaller question addressing only one aspect, like the interactionist approach used to explain schizophrenia or to treat. So you'll see in the final 2 slides of this presentation, there will be essay plans that make a distinction between what material you would use for explaining and what material you would use for treating schizophrenia. So in terms of explanation, the diathesis stress is an interactional model that has been used to explain schizophrenia. There are 2 versions of the diathesis stress model. The oldest, or the earliest model, had this idea that the kind of diathesis, that means the predisposition to schizophrenia, was given by a schizogene that made people more vulnerable to develop schizophrenia. However, they only developed that schizophrenia if there was a trigger, and that's the stress part of the diathesis stress hypothesis. So the people with the schizogene who had a schizotypic personality would develop the full-blown symptoms of schizophrenia if under stress, usually in childhood, potentially because of a schizophrenic mother. Now, the newer version of the diathesis stress model looks at predisposition in a more nuanced way. Not only genetic factors are seen as predisposing factors, but also factors that affect the development of the brain during childhood. For example, if someone has a psychological trauma in childhood, they might develop a hypothalamic pituitary adrenal systems, and that's involved in the kind of chronic long-term stress response that is hyperactive, meaning that they're more vulnerable to chronic stress. And that is the vulnerability, the predisposing, the diathesis element. Also, stresses can be both biological or psychological in nature. So it doesn't have to be an event that triggers the schizophrenia. It might be that if someone has a hyperactive stress system, then something biological such as smoking cannabis could trigger the development of schizophrenia. So that means that cannabis in itself is not a causal explanation for schizophrenia, but might be an exacerbating factor for people that have a hyperactive, for example, chronic stress system. The evaluation for diathesis stress comes from the study we mentioned before, Tianari, who found that there was a high risk of developing schizophrenia for children that both had a kind of genetic vulnerability from their biological mothers of schizophrenia and a negative family environment. There's also another study that says that combination treatments are much more effective than just medication, supporting the view that the cause of schizophrenia is never just one cause, and there's also various factors implicated in the development of schizophrenia, and therefore those various factors need to be addressed when treating the disease. The original diathesis stress model is oversimplified. That's why the second one was developed. And there are 108 candidate genes for schizophrenia, so it's impossible to talk about one single schizogene. And also stress can come in lots of different forms, and therefore the newer version, if you wanted to, you could also just describe the original version in AO1 and keep the newer version as evaluation in your AO3. Looking at specific evidence for the interactionist approach in treating schizophrenia, you can repeat the view that there's lots of evidence to support combined treatments as superior to any single treatment. Tarrier studied 350 patients that were allocated to one of three conditions. The control group received no treatment. The first two groups received a combination of psychological and biological treatment. And what they found is that the combination treatments were superior to any solely biological treatment, meaning that we've got consistent evidence for the effectiveness of combined treatments. And finally, here is a structure for a mini essay just on explaining schizophrenia using an interactionist approach. And this is the one for treating schizophrenia using an interactionist approach. All these essays are also on Quizlet, so don't forget to make sure that you're prepared for all of them. Good luck.